La siguiente conferencia se llama la acreditación y la atención centrada en el paciente. El beneficio es para todos. Creo que es un tema muy importante, cómo acreditación funciona y mejora los procesos de atención e impacta los resultados en la medida en que le sume otro pedacito a ese rompecabezas, y es que todo el proceso de mejoramiento tenga un propósito, que es el paciente, que creo que es lo que nos tiene a todos aquí sentados. La conferencista es una persona absolutamente espectacular. Yo puedo decir que es ya parte de la organización. Es la segunda vez que la tenemos, pero ya parece que la hubiéramos tenido con nosotros desde hace muchos años. La doctora Triona Fortune. Triona es la directora ejecutiva de la Sociedad Internacional para la Calidad de la Atención de la Salud ISQua. Su experiencia se centra en el desarrollo de la salud internacional y las normas de atención social, los sistemas de evaluación externa, especialmente el tema de acreditación. Ha asesorado a varios gobiernos, nivel macro, sobre las mejores prácticas para el desarrollo de sus planes de acreditación nacional, incluyendo países como Sudáfrica, Nigeria, Indonesia, Líbano, Nueva Zelanda, entre otros. Dirige el programa de acreditación internacional de ISQua, que acredita los acreditadores. Trabaja con la Organización Mundial de la Salud como asesora experta en varias iniciativas de seguridad del paciente, y antes de unirse a ISQua fue directora del servicio al cliente con los servicios de salud del Consejo de Acreditación de Irlanda y fue responsable de la implementación del proceso de acreditación en el 90% de las organizaciones de su país. O sea, es una persona que creo cuenta con toda la experiencia en el tema de acreditación, en el tema de seguridad del paciente. Sea usted bienvenida nuevamente, doctora Triona, a esta su casa.
Thank you, Louisa. That sounded wonderful. I don't think that was me at all, actually, so thank you so much. And thank you to Teresa for making this happen. It's so wonderful to be here. This is my second year in Colombia, but you know, it's wonderful for ISQua as well. We're just so happy to partner with OES because our mission and our visions are so similar. We want to improve quality, and we want to learn from you though as well. We're not the experts, we're all on a journey together. So I know it's 4 o'clock and we've had a wonderful day. So I really would like to rock on, as they say in Ireland, and speak a little bit more about person-centered care. So excellent, thank you. So some of the slides that I have, you'll notice, are similar to the slides of my colleagues. And I thought, oh, okay, I don't want to repeat. But then I thought, well, thank God for that we're actually all saying exactly the same thing. But I'm just going to come to it from a little bit of a different slant, from the slant of the patient. Now, I am an accreditation person. I don't, apologize about that. So obviously, I need to talk a little bit about standards. You've seen this slide before. These are the quality dimensions that we all use. They were written by the Institute of Medicine in 2001. And I'm going to talk there about the last one, patient-centered. I think it should be the first one. But as Wendy said earlier, they're all equally as important. We need absolutely all of them. Now, in 2001, this is the definition that the Institute of Medicine came up with for patient-centered care. Providing care that is respectful of and responsive to individual patient preferences, needs, and values. And I keep reading this definition, and to be perfectly honest with you, it really doesn't mean a huge amount to me personally. So why should we bother with patient-centered care? We know it's the right thing to do, but we need the evidence as well. And there is evidence out there. There's numerous research that says if you put the patient at the center of what you're doing, it will decrease mortality rates, hospital-acquired infections, surgical complications. It includes clinical outcomes. It supports medication safety. That's probably the one where the biggest amount of research has been done. Higher levels of staff satisfaction. That's something that Wendy said this morning. We also have to remember the staff within our hospitals, and it decreases malpractice claims. So the power of the patient. The World Health Organization started this movement in 1997. They started with the hand hygiene campaign, and they said that if you involve the patients in their own care, empower them within the hand hygiene movement, it will make a difference. Now, it has made some difference. I don't think it's made as much as it probably could have. Recent research has shown various different compliance rates throughout the world, from 40 to 80%. But on average, they are saying that it has improved hand washing by about 50%. So in ISQua, we decided that we would look at it ourselves. What was the definition of patient-centered care? We have two groups within ISQua. This is our patient forum. As you can see, they're from all over the world. And when we got them together a year and a half ago, they said to me, the first thing we want to work on is a definition of patient-centered care from an international perspective, because cultures are so diverse all around the world. And I have to say, the first thing I said is, this is going to take us about 10 years. There is no way we're going to get agreement from, people from the Lebanon, people from Israel, people from UK, America, etc. But, we started out, and it actually only took us 10 months to come to a consensus. They wanted to use the Institute of Medicine's quality dimensions because they're sound, we all use them, they're research-based. So they started off by using those quality dimensions, but then they said, we shouldn't be calling it patient, we should be calling it person, because it's not about the patient. And Enrique said that earlier on, it's about finding the human being. We're not there to look after a disease, we're there to look after a person. So that was the first thing they asked me to change. And they defined it as person-centered care is the care given in accordance with, and they wanted to do a diagram. The values, which are the center things there, respect, holistic care, partnership and compassion, and then the quality dimensions out around those. And the one different quality dimension there is transparency. So I'm just going to talk a little bit more about partnership. They actually said to me, it's not about person-centered care. It's about the partnership between the healthcare provider and the patient that's in the bed. Some of them want totally paternalistic relationships. They want to go into a hospital and they want to be told what the best treatment is. Some of them actually want to decide everything. They want to get the information and they want to go away and decide. So it's about forming that partnership and deciding what that partnership is. And the other thing that's different there is compassion. It's the care delivered with humanity, kindness, and warmth. And that's the bit about seeing the person, not the patient. And there's so much research out there about compassionate care. I won't go into those articles, but I can certainly give them to any of you that want them. That Twitter account down there, Hello, My Name Is, was started by a lady called Kate Granger in the UK in 2014. She was a doctor in the NHS that unfortunately got cancer, and she went into hospital to have her chemotherapy. And she found when she was in hospital that nobody wanted to ask her what her name was. And equally, nobody wanted to introduce themselves to her. And she thought it was such a basic, fundamental human relationship, kind of getting to know somebody, that she started this Twitter account. And to date, there's 1 billion hits on it. Everybody, from Don Berwick to Bono in U2, everyone has signed up to it. It's really made a phenomenal difference to getting the message out there to connect with the patient. So this is one of the ladies that are on her site. The lady in the bed there is a lady called Jean Marsh. She had 3 wishes at the end of her life. Unfortunately, she has since died from cancer. She wanted to see her dog Poddy again, who was 10 years old. They brought him into hospital to see her. She asked her daughter to reconcile with her husband. They'd been estranged for a number of years, and her daughter did that for her. And she wanted to see her horse, Bronwyn. She had raised this horse from a foal. He was 25 years old. And I mean, I still, when I see that picture, I'm such an animal lover. And to think that the nurses and the doctors in the hospital actually arranged for her to see her horse, it is such a human, kind, compassionate thing to do. You can see the smile on her face. And I think you can see the smile on the horse's face as well. Well, I think you can. And poor Jean died 4 hours after that picture being taken. So, there's nothing new about seeing the person in the patient. This is Sir William Osler. He obviously died there in 1919, but he was a doctor and he was a lecturer. He taught medical students, and his big message was, it's more important to know what sort of person has the disease than to know the disease the person has. So there's nothing new. We're just going back to basics. So getting back to our patient group in ISQua again, looking at the quality dimensions and the one extra one there of transparency. They actually define transparency as communicating honestly the care provided to the patients and, of course, their significant others. Now, we haven't been so great with transparency throughout the last 20 or 30 years. We do make mistakes. We've all made mistakes in our time. And we are starting to tell the patient that we've made mistakes. But unfortunately, we don't learn. So that might be a little bit of a joke there. Dilbert, the guy, goes to the doctor, and the doctor says, well, thank God you're not actually dying, but unfortunately your SMAP, your cervical smear test wasn't good. So another mistake. And as Einstein says, insanity is doing the same things the same way and expecting different results. As Rennie says, we need to actually think differently about how we do things. This is a big study that was done in 2000. I know it's a little bit old, but it goes back to communication. It was published in BMJ. It was a number of GP surgeries throughout England, and it was really interesting because they recorded the patients before they went into the doctor, they recorded them when they were with the doctor, and they recorded them afterwards. And the patients absolutely did not understand what was said during their consultation. I think they got 20% of it right. And we all know that patients actually only hear 30% of everything we say to them. We need to back it up with written information, nowadays apps, mobile phones, videos, etc. So I'm going to stop talking now for just a little minute and ask you if there's anything you can see wrong with this picture. The first thing is the photography isn't great. But this gentleman here, his name is Ted Kennedy. He has motor neuron disease, or I think you probably call it ALS here, but he has very little motor function. He can lift his right leg and his left little finger he can move. So just going back to one of the quality dimensions of safety and the other one about person-centered care. Now, if you shout up to me in Spanish, I'm not going to be able to understand you, so I'll have to deal with that. Anyone see anything wrong with? Anyone? He's going to fall. Very good. So he's in an office chair. He's not in a wheelchair. No, this is his home. He works from home. But he has a respirator beside him there because his breathing gets bad. But he will not use a wheelchair. Because Ted will not, he does admit he has motor neuron, but it's his independence. I'm a nurse, I'm also Ted's sister, and I have spent years fighting with him. He's going to fall, and I'm not going to be able to lift him up off the floor. So I'm a safety expert per se, I'm a nurse, I'm a carer. He's going to fall, what am I going to do? He's the patient, he's telling me I don't want to sit in a wheelchair. It's my choice, it's my independence. And in fairness to him, he still lives at home. He manages with the aid of carers and myself, and he does a great job. And he's one of the most positive people I've ever met. So throughout your careers, you're going to have to balance safety and independence, person-centered care. But it's just about, I said, see the person. So what can we do? We can do so many things as healthcare professionals. The most important thing, I think, is to give the patients the knowledge that they need. But we have to assess, they all have various different levels of health literacy. And it's nothing to do with intelligence. It's to do with where they're at in their life, their culture, how their emotional state. They could be very upset. They could have problems at home. So we actually have to assess all those. And we have to give them the assistance to make those decisions. And as Rennie says, and Sheila, and all the scientists, we have to measure their experiences, their outcomes, etc. So that's our job as healthcare professionals. This is one thing we shouldn't do, and I think this is the worst thing we can do. Say that we're person-centered, and we're actually not. And this was a study that was only done in 2009. It was presented at the ISQua conference. It was a study in 4 countries, Denmark, US, UK, and Israel. And they asked a number of clinicians, 1,004 nurses and doctors, were they person-centered? 90% of them said they were, and then they went and tested it. And actually only 16% were, slightly more nurses and 11% of doctors. And then they asked them, well, what would make a difference? And we've all said there are various different things that we need, and leadership is certainly one. So it's not just about saying you're person-centered, you actually have to do it. As Wendy said this morning, and Sheila, we need to be able to measure it as well. We can't improve what we can't see, what we can't measure. And because I'm an accreditation person, I think we need standards or guidelines or something as the benchmark. There are a number of standards that specifically look at person-centered care. There are accreditation standards. This is a study that we've done in ISQua. We collect all our data. Now in ISQua, we accredit the accreditors. We don't accredit at the hospital level. But this study spanned 3 years, and we actually changed our standards because we have to revise them every 3 years. And this was moving from one set, our 3rd edition, to our 4th edition. And you can see there at the top in the 3rd edition, there was a lot of recommendations within our reports on patient service user focus. But when we came down to the 4th edition in 2014, it had actually become less. So we know that that accreditation system within our accreditation organizations has actually improved things. So that was good. Safety had improved as well, but I'm talking about person-centered care. I'm delighted to say that the standards here in Colombia, the ministerial standards, thanks to the work that Teresa and OES done, have been accredited by us. We've accredited 150 sets of standards all around the world. So that means that these standards are as good as the other 150 standards. They're as good as Accreditation Canada, ACHS in Australia, JCI in America, people in Europe, etc. And I believe that they're there for free. Teresa Tano and OES will send you a copy of them. You don't have to pay to go through a full accreditation system. Use the patient-centered care standards in those. Use all of the standards. Just self-assess yourselves. Do a gap analysis. You don't have to have other people come in. It's always good that you do because it helps you on your quality improvement journey, but use those standards. There's lots of other standards. PICR started in 1987. Harvey Picker had a huge amount of money and he left it to the Picker organization, and they did a huge amount of research into the principles and the values of person-centered care, and they came up with 8 goals. They still do surveys in the US and they still have offices in Europe, and they do a number of measurements now through adults and peds. Their pediatric evaluation surveys are actually quite good, so they're there free as well. Plaintree, you're going to hear more about Plaintree, so I'm not going to go into that, but there's standards out there as well within the patient-centered care realm. I would say to you, you don't need everything. You don't need Accreditation and Plaintree and PICR because they're all going to do exactly the same thing. Pick one and do it well. Culture. I'm really privileged with ISQua that I travel all around the world. And people say to me, well, you know, we can't do person-centered care in this country because it's not within our culture, especially in the Middle East or in places like Malaysia. But Malaysia did a study 2 years ago, and they actually showed, and they have 29 million people from various different backgrounds, Malays, Chinese, Indians, so many different religions. Obviously, they have a large proportion Muslim. But they actually showed through their accreditation that they could do person-centered care, and it was improving year on year. It was slightly better in the private hospitals than it was in the public. So getting back to the measurement, as what René says, we can measure reactively. We still have to continue to measure adverse events, complaints, investigations. It's another debate whether we do it anonymously or not. But the one thing about it, and this is the Francis report that Wendy alluded to, and it's the same in every country. We're great at producing reports. So after the Francis report in the UK, there was the Berwick report, then there was the Keogh report. We need to do something with all of the recommendations in these reports. I was lucky enough to be involved in Ireland with an investigation, the first one we did into cancer misdiagnosis in 2006. And 10 years on, they're still producing the same recommendations, governance, person-centered care, standards, etc. So we just don't seem to be moving on quick enough. But we need to be proactive as well, as René said. We need to measure satisfaction surveys, experience, but now there's things called PROMs, PREMs, and PAMs. Kind of sounds like a groovy boy band, but it's not. It's all about patients measuring themselves. So PROMs are patient-reported outcome measures, PREMs are patient-reported experience measures, and then patient activation measures are how we communicate. And they're things that patients are going to do themselves, and we just need to listen to how they measure, because they need to be responsible for their own care as well. So what is the future going to look like? It definitely has to look like a partnership between patients and health carers. There are going to be so many more IT tools. I mean, the mobile phone, the apps, we don't leave them out of our hand nowadays. But remember the human contact. I went into my local store recently to buy a bar of chocolate, which is a little bit of a guilty pleasure for me. I love chocolate. And the lady behind the counter had gone, and I had to scan my bar of chocolate and put in my Visa card to buy it. And I wouldn't do it. I said, no, I need to go up to somebody and give them my money and talk to them and get my bar of chocolate. So I did that about 3 times, went into the shop and came out without the chocolate. But on the 4th time, I used the scanner because I wasn't getting any chocolate. So we will give in and we will learn to use IT. But remember, don't lose the human contact. It's just so important. Now, as I said at the beginning, why should we bother? And this is one of the reasons that I bother. This is a person who was very dear to me. This is my mother-in-law, Molly Fortune, who unfortunately died last year. But we kept her at home. And this is my dog, Scamp. And she asked to see my dog. I don't think she was interested in seeing me or my husband, who's actually her son. But that's all she wanted. She wanted the dog. She wanted to be kept at home. And we did that because she went into hospital on numerous occasions, and they got her up at 6 o'clock in the morning because that was the only way they could run the ward. They had to get her up at 6 o'clock so that they were ready to do their drug round at 8. They had to wash her at 7:30 and sit her out in a chair. The woman was 93 years of age. You know, it wasn't fair on her. So we managed. We were very fortunate. Not everybody can do that. So what I'm saying is, find your person and remember who they are, and just don't lose the human contact. So thank you so much.